One. Good morning in Miami. This is Dr. John Bennett. It's morning in Miami, but it's evening in Korea and Japan. Today is a groundbreaking event, the first broadcast of Korea Medical TV. We have Hee Young Kim MD, an ENT doc from Korea, and joined by a panelist, Simon, the member of the team, a medical student from Japan. So first, we'll let Simon introduce himself, and then we'll turn it over to Hee Young. Good day, Simon. Well, good night, Simon.
Both. Good evening and good day. I'm looking forward to this presentation. My name is Simon Downs. I'm a medical student in Tokyo. I'm a student at Oceana University of Medicine, and I'm also working with an ENT doctor from Tokyo, and he is developing a very powerful hearing aid.
Very good. And we'll try to get him on a hangout eventually, too. So welcome, Hee Young. It's all yours.
Yes. Hello, Dr. John Bennett. I'm in Seoul, and I work in my private ENT clinic. I'm an otolaryngologist. I'd like to talk about reciprocal causal relationship between laryngopharyngeal reflux and Eustachian tube obstruction.
Okay, very good.
Yes, now I will share my slides.
Okay.
I'm ready. Just a moment.
Okay. Very good.
Okay.
Yeah, very good. We can see it.
Okay, I'm starting.
Okay.
Thank you, Mr. Chairman, Dr. John Bennett.
Okay.
And Dr. Simon. Today, I'd like to talk about reciprocal causal relationship between laryngopharyngeal reflux and Eustachian tube obstruction. My own experience has proved that many cases have both laryngopharyngeal reflux, LPR, and Eustachian tube obstruction, ETO, at the same time. I reasoned that Eustachian tube obstruction can be a cause of LPR, or conversely, laryngopharyngeal reflux can be a cause of Eustachian tube obstruction, and realized keenly the necessity of definitizing the cause and effect relationship between both of them, and it should be universally applicable to management of many cases of this type. We will discuss Eustachian tube catheterization using devices like Eustachian tube catheter and Toynbee diagnostic tube. Blocked Eustachian tubes or Eustachian tube obstruction can cause several symptoms, including ears that hurt and fearful ringing or popping noises, hearing problems, feeling a little dizzy. These symptoms can be regarded as major in multiple symptoms originated from Eustachian tube obstruction. Though Eustachian tube obstruction is one of the principal causes of hearing loss, and earfulness, and dizziness, vertigo, and tinnitus, and headache, migraine, including otalgia, was already recognized by many well-respected senior doctors a long time ago. It has still received but scant attention, both in the literature and in practice for a long time. Especially in the cases complaining nausea, vomiting, and perspiration, accompanied concomitantly by vertigo, which are attributable to Eustachian tube obstruction. Their physicians tend to fail to recognize the cause in the emergency room or outpatient clinic. It's true, of course, that there are many other conditions which may cause vertigo, but since obstruction of the Eustachian tube is one of the most obvious and also the most easily corrected. Every patient with symptoms of dizziness and nausea, vomiting, and perspiration should be subject to the therapeutic test of inflation of the tubes as a first step in a thorough clinical investigation. Dizziness or vertigo from Eustachian tube obstruction can be explained by increase of inner pressure of vestibular organ. It is because negative mid-ear pressure gives rise to the retraction of tympanic membrane, and it makes the stapes push against the oval window. It seems obvious that obstruction of the Eustachian tube somehow disturbs the air pressure and causes stimulation of the perilymph, which interferes with the normal balance as maintained by the Laryngealpharyngeal mechanism. Electrical activity generated within the inner ear travels along the vestibular nerve to the central vestibular nuclei of the brainstem, forming second-order neuronal pathways that become the ocular reflex, the vestibular spinal tracts, and the vestibular cerebellar tracts. Pathways derived from vestibular information also travel to the brainstem emetic centers, which serves to explain vegetative symptoms such as nausea, vomiting, and perspiration that a patient typically experiences following an acute unilateral vestibular loss originating from acute unilateral Eustachian obstruction. We can realize that electrical activity generated by Eustachian tube obstruction travels to the brainstem emetic centers and causes symptoms such as nausea, vomiting, and perspiration after all. Here, we need to remember this clear proposition that Eustachian tube obstruction is the obvious cause for loss of vestibular function. Unilateral peripheral vestibular loss with a loss of unilateral vestibular function. The patient acutely experiences the sensation of true vertigo from interruptions of vestibular ocular reflux pathways and tends to lie perfectly still, as any movement aggravates vegetative symptoms such as nausea and vomiting that arise from the emetic centers. Nystagmus beating away from the side of lesion is the cardinal physical sign that obeys Alexander's law. The vertigo is caused in most instances, and perhaps in all, by unilateral Eustachian obstruction or by more complete obstruction on one side than the other. The direction of the gate furnishes a clue to the side, which may be affected, for in most of the cases, the staggering is in the direction of the obstructed side. With compensation, there may be minimal symptomatology that is only brought out by very rapid head movements. The spontaneous nystagmus disappears, vegetative symptoms resolve, gait improves, and in the case of a chronic condition, the patient may experience only a slight imbalance when turning quickly. This point can be the reason why any vestibular function test should never be performed before correction of Eustachian tube obstruction and without normalization of mid-ear pressure and tympanic membrane retraction. Bilateral peripheral vestibular loss. Vertigo is not a feature of a bilateral vestibular loss even when it occurs in an acute fashion. Instead, the patient tends to complain of oscillopsia and imbalance. The gait is typically broad-based and ataxic, especially with eyes closed. Falls are not infrequent then, and in many instances, the patient requires assistive devices for ambulation or is relegated to a wheelchair. Compensation is generally unlikely to occur despite the best efforts. of vestibular rehabilitation therapy and greater reliance on information from visual and proprioceptive receptors. Right now, it is reasonable to ask some questions. What is the normal parameters of middle cavity pressure that never make any impact on the vestibular function? What is the normal criteria for difference of pressure between both middle cavities that never make any impact on the vestibular function? What is the reference point in order to differentiate between unilateral Eustachian obstruction and bilateral Eustachian obstruction? The cases of insidious onset are the ones most likely to be overlooked in these instances because the gastrointestinal symptoms are predominant. The patients are likely to be subjected to various types of treatment over long periods for diseases of the digestive system. While vertigo originated from Eustachian tube obstruction is a distinctive clinical entity, they ignore the possibility that the violent symptoms of dizziness, nausea, vomiting, and perspiration can be originated from Eustachian tube obstruction. The reason is that some of the physicians, audiologists, otolaryngologists, or even otologists are likely to think in terms of disturbances in the digestive, circulatory, nervous systems, or only vestibular organ function, and usually examine them just stuck in the rut. When the onset of the symptoms of nausea and vertigo is sudden and severe, the diagnosis is more easily established, and if the proper treatment is instituted promptly, the relief is striking and dramatic. The gastrointestinal symptoms of the cases of insidious onset can also be regarded as symptoms of LPR or GERD. Hence, we can accept an Cartesian intuition that every variable symptom and disease-associated LPR or GERD should be included in the multiple symptoms and diseases originate from Eustachian tube obstruction. We must pay attention to necessity that cases of insidious onset are subjected to Eustachian tube catheterization. There are symptoms and clinical manifestations reported to be related to laryngopharyngeal reflux. On the grounds that LPR or GERD can be the direct result of the Eustachian tube obstruction, I strongly urge that Eustachian tube obstruction should be included as a direct cause of LPR or GERD academically. In the patients having both LPR and ETO, okay. In the patients having both LPR and ETO, ETO is not just a cause of LPR as seen above. On the contrary to this, LPR can be a cause of intrinsic mechanical obstruction of Eustachian tube, because reflux contents from stomach can reach the nasopharynx and the Eustachian tubes through esophagus and block the tubes directly or cause inflammation of the mucous membrane lining of the Eustachian tube or adhesion and collapse of it. Some studies by Alsop et al. Show laryngopharyngeal reflux plays an important role in the pathogenesis of otitis media with effusion, as gastric reflux reaches the middle ear through the nasopharynx and Eustachian tube to cause otitis media with effusion. Consequently, the concept of reciprocal causal relationship, both of laryngopharyngeal reflux and eustachian tube obstruction, which cause a vicious cycle, is established distinctively. Treating patients, regardless in an emergency room or outpatient clinic, a wide and diverse variety of symptoms originating from laryngopharyngeal reflux or gastroesophageal reflux disease and eustachian tube obstruction has to be considered with the mutual connection of servantability. As mentioned earlier, because eustachian tube catheterization may be of both diagnostic and therapeutic value, they should be subjected to the therapeutic test of inflation of the tubes as a first step in a thorough clinical investigation. Moreover, it is established that every clinical test being used in the assessment of vestibular function should be performed in the state of ideally normal mid-rear cavity pressure with perfectly equal balance between both ears. Let me show you these eustachian tube catheters, which I use myself in my clinic at present. There are 4 kinds of size of them. The number and colored mark of each catheter are scaled according to the diameter of catheter. Toynbee diagnostic tube. This is a stethoscope-like device used to examine and listen to the eustachian tube. This is eustachian tube catheterization. This procedure is more than a century old and was earlier routinely done to check patency of the eustachian tube. The important thing to remember is that the method only tests the patency of the eustachian tube and does not reflect on its function. This is me. Now I am practicing eustachian tube catheterization in my private clinic. Let me compliment you very much for your attention.
Thank you very much.
Very good, Hee Young. Thank you very much for a very clear presentation and a good PowerPoint presentation. And Simon, I'll let you go first because you have a good ENT background.
Okay, thank you. Well, I'm just a learner in the ENT industry. I'm working with an ENT professor in Tokyo on a hearing aid, but in that area of the body, I'm very interested. Regarding this procedure, this is a relatively new idea, and what are alternate ways to diagnose an obstruction? You always have to use eustachian tube catheterization, or is there another way? It seems very invasive. Are there any risks with this procedure?
Yes. Most people are considering about the risk of eustachian tube catheterization. Some says that it is very dangerous and it is make a damage to eustachian tube orifice, but the end of eustachian tube catheter is very dull and smooth. So there, I believe that there is no possibility of damage. I have never experienced any complication of eustachian tube catheterization.
I see.
First, I will practice eustachian tube catheterization with tympanometry and pure tone audiometry. They are necessary, but not sufficient. So, eustachian tube catheterization is necessary. I believe so.
You know, Simon, there's no imaging studies to diagnose eustachian tube obstruction, like MRI or something like that, or it's too small to really see on MRI. Do you know anything about that?
MRI?
Yeah, is there any imaging studies to show?
MRI and CT it can be helpful for diagnosis of eustachian tube obstruction.
Okay.
But as a disease,
okay,
some says that it is not a disease. Eustachian tube obstruction is another disease.
Okay.
Because the result of the impedance tympanometry is classified as the type of graph, type A, B, AS. So dizziness it is impossible to realize the cause of dizziness due to eustachian obstruction. It is impossible without eustachian tube catheterization.
Oh, okay. Now, go ahead, Simon.
Thank you. I was wondering, would you be able to teach other ENT doctors how to do this procedure quite easily, or would this take a lot of training? How quickly could you teach another ENT doctor?
Most otolaryngologists didn't learn how to practice eustachian catheterization. I think that it is due to apprenticeship from teacher to teacher teach it to their most loved students.
Could you teach that on a Hangout, or could you teach that with a? I mean, for example, if you did a Hangout
from now, it is possible.
Procedure.
I think so.
Yeah, that would be very interesting to see how you do it exactly. I was looking at your article and trying to find anyone in America or Japan who has done similar procedures, and there are very few people. So I think it would be very interesting to share your expertise.
Yes, I will try.
Mm-hmm.
That's the benefit of the internet, where it allows us to bring doctors from other countries to the internet, talking about procedures like this that other doctors may not know about. It can apply to other fields too, neurosurgery or whatever.
Yeah.
So, you know, as far as the treatment, Dr. Kim, maybe I missed something, but when you do the catheterization, do you attempt to suction the tube so that to clear the obstruction?
A suction?
Yes. Do you try to clear the obstruction?
Yes. Yeah, it is very important.
Okay.
If discharge or secretion remain in the nasopharynx, when I will do eustachian tube castration, the discharge will go to the eustachian tube with air.
Okay.
Maybe it can be more harmful. So I need to suction the discharge on the nasopharynx.
Okay.
Yes, that's what I was reading about. That is the greatest danger.
Perfect.
Air.
You're really introducing air?
Valsalva maneuver is very more harmful. It is very dangerous because the patient can't regulate the strength of pressure.
Okay.
Yes, yes.
Okay.
Eustachian castellation is safer than Valsalva maneuver. I believe so.
Do you put the patient on antibiotics after the procedure?
Yes, yes.
Okay.
Anti-inflammatory medication and antibiotic medication.
Well, what type of medication do you use? Ancef, Keflex, cephalosporins?
I first choice antibiotics.
Okay.
Augmentin or macrolide. Yes.
Fourth generation.
Okay. Macrolide. Okay.
Macrolides.
Okay. Well, I know you want to use the word reciprocal. Can you use reciprocal in an answer?
Reciprocal. Is it right?
Yeah. Reciprocal. How can we use reciprocal here, Simon? In what context?
Is it good choice?
Yes, that's a good
by
word.
me?
That's a good
I don't
word.
know. I don't know.
That's a good word. Just a little comic relief for this hangout here. Anyways, Dr. Kim, I'd like to thank you for a good presentation, and thanks, Simon, for coming.
My pleasure. Very interesting.
We look forward. We're going to do this hangout in Korean for Korea Medical TV. So
Yes.
thank you, gentlemen, and good day and good night.